In the last class, we have discussed the acute respiratory distress syndrome, its definition and causes. Now we will see pathophysiology of acute respiratory distress syndrome. This is a schematic representation of pathophysiology of ARDS. We can see here lung injury. Lung injury may be resulting from any of the given causes which we have seen already. Due to lung injury, it can result in release of vasoactive substances. These are the inflammatory mediators, that is serotonin, histamine, bradykinin, etc. These vasoactive substances will be released from the damaged cells. This vasoactive substance can cause bronchoconstriction, and bronchoconstriction, it can impair the gas exchange directly, and it can lead to vascular narrowing and obstruction. When there is vascular narrowing and obstruction, that also the blood supply through the capillary will be reduced, which results in impairment in the gas exchange. In the same way, here pulmonary, this vascular obstruction can lead to pulmonary hypertension, and pulmonary hypertension can directly result in ARDS. And also it increases alveolar capillary membrane permeability. That is a most important change. That is these vasoactive substances or the inflammatory mediators that causes or increases capillary membrane permeability, and it can lead to outward migration of blood cells and fluids from capillaries. From the capillaries, when there is increased capillary membrane permeability, the blood cells and fluid from the capillary, it escapes into the interstitial space, and from there it enters into the alveoli, leading to pulmonary edema. And here lung injury also can lead to damage, or it can damage the type 2 alveolar cells, which decreases surfactant production, and alveolar compliance and recoil will be reduced, leading to atelectasis. Then hyaline membrane formation, and also decrease in lung compliance, which causes impairment in gas exchange. This is the pathophysiology of ARDS. We will see each one in detail. This is a hypoxic pulmonary vasoconstriction. This we have already seen how the shunt is formed. That is, we have already seen in respiratory failure. We have studied. Here you can see the normal vessel from here, that is a pulmonary artery. It surrounds, or it encircles the normal alveolus, and blood gets oxygenated and it flows to the pulmonary vein. It joins to pulmonary vein. But here see here from the pulmonary artery, this branch, there is alveolar capillary constriction, and the blood flowing through this artery or pulmonary capillary will be less, and the gas exchange will not take place here directly. It bypasses, and the deoxygenated blood itself enters into the pulmonary vein. Then it results in when the gas exchange is compromised or impaired, it results in hypoxia. When there is hypoxia, there will be increase in the respiratory rate, and there is decreased tidal volume. When the respiratory rate increases, carbon dioxide will be removed faster, which leads to respiratory alkalosis, because oxygen exchange will not take place. Oxygen exchange will be less when compared to carbon dioxide removal. That leads to respiratory alkalosis, and there will be increased, as a compensatory mechanism, there will be increased blood flow. Increased blood flow leads to increase in pulmonary shunt. When pulmonary shunt is increased, that leads to hypoventilation and decreased carbon dioxide removal and decreased tissue perfusion. Okay, that is the pathophysiology. There are three phases for ARDS, that is exudative stage, proliferative or fibroproliferative stage, and a fibrotic stage. injury or exudative stage, it is a it takes 1 to 7 days. That's the period of this exudative stage, usually 24 to 48 hours. The characteristic features of this exudative stage is development of intrapulmonary shunt, hyaline membrane formation, decreased surfactant production, bronchoconstriction, which is resulting from inflammatory mediators. This is the development of intrapulmonary shunt. See, when there is injury, I have explained it now. Just in the previous slide, I have explained it. When there is an injury to the lungs, that causes inflammation. When there is inflammation, neutrophils adhere to pulmonary microcirculation. Okay, neutrophils adhere to pulmonary microcirculation. It causes damage to the vascular endothelium, and which increases capillary permeability, and then interstitial edema develops. Fluid from the interstitial space crosses alveolar epithelium and enters alveoli, which leads to intrapulmonary shunt. See, this is a normal alveoli. This is the capillary through which the blood flows. When there is inflammation, the neutrophils adhere to this wall of this capillary, which increases the permeability. From the capillary, the blood cells enters into the cells as well as fluid enters into the space, interstitial space, which causes interstitial edema. From there, it enters into the alveolar cavity, and pulmonary shunt develops. This is the picture of pulmonary shunt. Then hyaline membrane formation. It is due to activation of neutrophils. When there is activation of neutrophils, fibrinous and purulent exudate forms. Okay, this hyaline membrane is formed by necrotic cells, protein, and fibrin, and this leads to hyaline membrane formation. Hyaline membrane formation, see here, this is the normal one. This is the this is the alveoli, and how the gas exchange takes place you can see here. But this is a hyaline membrane formed. Okay, and the gas exchange will not be possible from the capillary to the and between the capillary and the alveoli. So this is the next one is decreased surfactant production. Surfactant means the function of surfactant. It maintains alveolar stability by decreasing surface tension. Okay, that is the function of surfactant. When there is damage to alveolar cells, the surfactant production will be decreased, which leads to decreased alveolar compliance and recoil, and in turn it causes atelectasis. Okay. Then damage to the alveolar cells decreases lung compliance, which increases or causes ARDS. Then phase 2, that is proliferative or reparative phase. It begins in 1 to 2 weeks after initial injury. Due to the inflammatory response, there will be influx of neutrophils, monocytes, and lymphocytes, and also fibroblasts. Forms a dense fibrous tissue, that is the interstitial fibrosis. This is known as interstitial fibrosis. When there is interstitial fibrosis, there may be destruction of pulmonary vasculature. When pulmonary vasculature destruction is there, it increases pulmonary vascular resistance, leading to pulmonary hypertension. Then interstitial fibrosis decreases lung compliance. It also thickened alveolar membrane can cause hypoxemia. If phase 2 persists, widespread fibrosis result. If arrested, lesions resolve. Then phase 3, that is fibrotic phase, it is also called chronic or late phase. It develops in 2 to 3 weeks after initial injury. Completely remodeled by collagenous and fibrous tissue. Diffuse scarring and fibrosis results in decreased lung compliance. Surface area for gas exchange decreases, and as a result hypoxia continues. Pulmonary hypertension results from pulmonary vascular destruction and fibrosis, that also will be increased. In the stage 2 or phase 2 itself, we have seen pulmonary hypertension, and that will be increased and here in this stage, if the patient reaches, the prognosis is poor. Here you can see the changes in the exudative phase, that is epithelial damage, endothelial damage, inflammatory cascade, pulmonary vascular permeability increases, then lung matrix alteration and coagulation and fibrinolysis, and if the stage is arrested here, the lung resolves and the patient gets back to normal stage. And fibroproliferative phase, here also see here fibroblast proliferation, you can see here. See here fibroblast proliferates. See here this is the fibroblast proliferation. Here also you can see fibroblast proliferation. Okay, that is the stage or a phase 3. That's about the pathophysiology of ARDS.